everyone. We're going to give it a few minutes while people start to join this morning, but happy Saturday. We are so happy to have you this morning and part of our gluten challenges and celiac disease. Our conference, we have an amazing lineup of speakers today. And my name is Rachel Lieberman. I am a director here at the Celiac Disease Center. I am really happy to have everyone with us this morning. I'm going to go over a few housekeeping rules and then introduce some of my amazing colleagues. So I just want to remind everyone today's session is being recorded. If you have to drop off for any reason, this will be posted on the website in which you logged in today in about 3 days. The recording will be there and accessible for about 30 days. So if for any reason you do have to jump off, this is a way you can still watch the conference. I wanted to also let you know that this Q&A function at the bottom of your screen is going to be really important. We would love throughout talks if you could give all of our speakers questions in that Q&A function. The chat is not actually for Q&A. It helps us stay organized for when we have our panel discussions. So please utilize that Q&A function at the bottom of your screen. And on the website, when you entered in, there are instructions on how to claim your CME credit. And those will again be sent out right after the conference. And any other CME information that you need, you can log into our website right at the bottom, scroll to CME information. And there's also a contact information, but please submit all your questions. We want this to be a really meaningful discussion during our panel discussions so that we would love to have your questions. But I am so happy to be joined today with our amazing committee who pulled this morning together. I have my colleagues with me, Dr. Bana Jabri, who is our research director of the Celiac Disease Center, and she is the Sarah and Harold Lincoln Thompson Distinguished Service Professor of Medicine, amongst many other titles. And we are so happy to have Dr. Bana Jabri with us today, as well as Valerie Abadi, who is a research associate professor here at the University of Chicago, Department of Medicine in the section of gastroenterology. And we are so happy to have Dr. Abadi, who was such a meaningful part of helping plan today. So thank you, Valerie. And finally, Dr. Ritu Verma, who is also obviously with us at the University of Chicago. She is our section chief of gastroenterology, hepatology, and nutrition at Comer Children's and the medical director of the Celiac Disease Center. So Dr. Verma, I would love to hand it over to you to kind of set the stage for this morning, and I want to thank everyone for being here.
Good morning, Rachel. Thank you so much. And thank you everyone for joining us. We have clinicians, researchers, dietitians, psychologists, patients, parents, families. Welcome. That's what the Celiac Center is all about. It's a combination of the clinical teams, the research teams, and our patients. So hopefully we'll be able to talk a little bit about celiac disease. You know, celiac disease, as I'm sure anyone who's in either the field of celiac or experiencing celiac disease will realize that it could be very simple, right? You go see your doctor, you have the classic GI symptoms, you have pain, diarrhea, weight loss, you have a clinician who orders the panel and makes a diagnosis, biopsies done. And that's simple, relatively speaking. You get a diagnosis, you see an experienced dietitian, you go on your world. And then you have some patients that don't have the classic symptoms. They have joint pains, headaches, other sorts of symptoms that happen. Now it requires a clinical team to think about celiac disease. And that makes it a little bit harder because now we have to start thinking about all of these other symptoms that are not traditionally thought to be part of celiac disease. Again, an experienced group will order the tests. Your primary team has your local gastroenterologist on speed dial. You get a diagnosis made with the blood work and the biopsies. So again, took a little longer journey and the diagnosis is made. There are some other people that actually will have some symptoms, maybe symptoms, no symptoms, but they get a blood test done. And you'll hear more about this from Dr. Semrad, but you get a blood test done and voila, it looks like it must be celiac disease. And you go see your gastroenterologist, you have an endoscopy done, and oh my goodness, maybe not the classic sort of features of celiac disease. So what do we do then? And that becomes really a challenge. All of the others are challenges, but this is another challenge. What do you do with a person who has maybe some symptoms, maybe not some symptoms, has blood tests that are abnormal, and then has a biopsy that doesn't follow the path that normally does from a celiac standpoint? So that becomes the big challenge. And it was one of our discussions in our organizing committee where we thought, what do people do with that? Do I introduce gluten? Do I not introduce gluten? Do I go on a journey of being a celiac disease patient? And if I do go on a journey of being a celiac disease patient, do I really have celiac disease or not? And then I go on a gluten-free diet, and now I have a question. Do I really have celiac disease? Because my next door neighbor who has celiac disease tells me that he or she had an endoscopy which clearly showed there was biopsy changes. And now I have to reintroduce gluten. Should I? Should I not? How much gluten should I take? How long should I be taking that gluten for? All of these are questions that come on as dilemmas, challenges for your clinical team. And then we go off to our researchers, and Dr. Jabri is one of those researchers that I have the pleasure of working with, to ask her, okay, so now we have our patients who go and we give them gluten. We don't know how much, but hopefully by the end of this morning, we'll have had more discussions from our wonderful researchers. What happens? So if someone who has celiac disease with this question of celiac and you now give them gluten, what happens? And I think that hopefully this morning, we'll be able to outline some of these real challenges of how much gluten, when should we give the gluten, do we really need to do that? And if we do that, is it harmful? Is it not harmful? Do we have research to support us? Do we need to do research to figure out? So these are all the questions that we face as people, clinical people who are managing patients. These are the questions we face as parents if we have children who are in this diagnostic dilemmas of celiac disease. And we are going to set the stage today to have some discussions. Do we have all the answers? No. Do we know where to go with these questions? Perhaps yes. Will we conclude with something? I hope so. So at this point, what I'm going to do is introduce Dr. Valerie Abadi again to come back as part of our research team, and we'll set the stage for our morning session where Valerie will start it off, and hopefully by the end of the day, we'll have had some of these questions answered. Please don't forget questions and answers in the Q&A. Thanks, Valerie. No problem.
Okay, good morning, everyone. So this morning, I'm going to introduce a few of our speakers. And our first speaker today is Dr. Carol Semrad, who is a gastroenterologist and the primary adult celiac disease specialist at the University of Chicago. She's a member of the medical leadership team at the University of Chicago Celiac Disease Center. And she's going to start this symposium this morning, talking to us about and giving us an overview about what's a gluten challenge. So Carol, you can share your screen.
Thank you, Valerie, and good morning to everyone out there. So I'm going to talk today about celiac disease and the overview of a gluten challenge. And I have no disclosures, and I will not be discussing any off-label use of any medications. And the first step is to really define what is gluten, because that's really what triggers this disease. And so it's important to understand what the molecule, what the antigen is, and where is it. So it all starts out in this family, subfamily and tribe of patients. Oops, sorry. And in the Triticea tribe, there's wheat, rye, and barley, and that has these toxic peptides to patients with celiac disease. And these are the so-called alcohol-soluble prolamines, the gliadin, scalene, and hordein present in wheat, rye, and barley. And what they have in common is that they have a high prevalence of the amino acids glutamine and proline. And you can see if you look at oats, it's high in glutamine, but not proline, and rice and corn are high in leucine and alanine, and so they're very distinct in terms of their amino acid structures. So the toxic molecules are these predominantly gliadin alcohol-soluble prolines, but just to use a common term, we call them gluten peptides because there are some other proteins in gluten that can trigger disease. So we use the common term gluten peptides. So what do we know about the key steps to triggering the celiac disease? We know that environmental factors, particularly gluten, is required. And we know that gluten is not well digested by humans. So when we eat gluten, we're left with these sequences of amino acids called peptides that then can get across the epithelium. And one of the areas we understand probably the least well is how these peptides are getting across that epithelium. Are they going through the spaces? Are they going across the cell? And what kind of processing might occur? And this comes into play when we talk about a gluten challenge and how easy or difficult it is to trigger the disease back. Then, of course, many great scientists over the years have put together the rest of the puzzle, not all of it, but a large part of it. And we know that these peptides, once they get across the epithelium, there's an enzyme called tissue transglutaminase 2 that's capable of turning these peptides into more negatively charged immunogenic peptides. And then in the right genetic background of the HLA-DQ2 or the HLA-DQ8 patient, these negatively charged peptides can bind to the antigen-presenting cells, and then the T cells can come in and be activated and release these gluten-specific T cell responses. A large one that's very important is gamma interferon, but we also know that there's a reaction that occurs up in that epithelium as well that releases IL-15, which is key to causing intestinal villus atrophy. So that gets on to how does inflammation actually lead to this villus atrophy, because it's the villus atrophy that decreases the ability of people to absorb nutrients and lose weight and become sick. So we know that it's gluten, and we know that IL-15 and interferon gamma are two of the key players that cause this villus atrophy, but it's still quite a mystery. We don't know everything about that process, so we need to clearly learn much more. And then the other unique thing about celiac disease at the intestinal level is that there's recovering when you put a villi, when you place a patient on a gluten-free diet. And so on the left, you see a patient's both endoscopic appearance of their duodenum. You see these little ridges across that duodenal fold up on top. And on the bottom, you can see the inflamed bowel here in the both underneath the epithelium and at the surface. And you can see these villi are completely lost. You have these long crypts and inflammation that spreads apart these crypts. This is a severely inflamed bowel. On a gluten-free diet, there's recovery, and you can see here, instead of being flat, the villi are coming back. There's still a bit of long crypt here, so it's not 100% back, but it's markedly improved from what this baseline state was when this patient was eating gluten. So let's talk now about the gluten challenge. So first of all, just to get to diagnosis, if I can just set back here, it was the discovery of tissue transglutaminase as being the autoantigen of the endomysial antibody. And by many, many studies, it's been now shown that both the endomysial and the tissue transglutaminase antibodies are the most sensitive and specific for celiac disease, and they really are important in making a diagnosis. In other words, when they're positive and you have the right type of bowel inflammation, then the diagnosis of celiac can be made. Now, as Dr. Verma stated, some people have a positive antibody and the tissue looks normal, or the tissue looks abnormal and there's a negative antibody, and these become diagnostic dilemmas that we have to sort out. So getting back to the gluten challenge, first it's important to know, what do we know about how much gluten triggers celiac disease? And these were studies there were other investigators, they're all small studies on a limited number of patients. But I think the ones that the two studies by Katasi help define what that threshold amount of gluten is that's safe to be in food, because gluten-free food, of course, is not completely gluten-free. It's less than 20 parts per million gluten. So at the top, you can see when individuals did these experiments, they either used pure gliadin as the antigen to trigger the reaction, or gluten. And just to set the stage, 100 milligrams of gliadin is essentially 200 milligrams of gluten. So you double it if you're looking at a study using gliadin versus gluten. But in the more recent 207 studies, when investigators were looking at what is that threshold amount, 10 milligrams given to a patient orally for 3 months mainly caused no symptoms, but there was one patient, that's 6%, who actually had vomiting, diarrhea, and abdominal distension. Now, the question is always, it can be anxiety provoking to challenge people with gluten. So you always have to take into account symptoms that may be coming from just some underlying anxiety about it versus the true gluten reaction. But needless to say, this patient had what we think are traditional responses to a gluten challenge triggering bowel inflammation. But some patients in these studies can actually trigger at 5 milligrams. So there's a sort of a variety here of dosing that can trigger symptoms in any individual patient. At 50 milligrams, 3 months, no symptoms, and permeability testing was not done in this study. But here you can start seeing changes on the intestinal biopsy, not so much increase in intraepithelial lymphocytes in these patients, but a decrease in villus height to crypt depth, which means they're starting to develop villus atrophy. If you look then at the study that was done in 1993 at 100 milligrams of gliadin, which is a much higher dose than 50, at 1 month of challenge, no symptoms, normal permeability in these studies, but here you start seeing increased lymphocytes, intraepithelial, and decrease in villus height to crypt depth. And at 500 for 1 month, everyone got symptoms. Their permeability was increased, and there was a much more marked reaction to by way of increased epithelial lymphocytes and the villus height crypt depth ratio. So based on this, we think 50 milligrams may be too much, but less than that is probably safe in most patients. Now to talk to how much gluten does the average person eat in a day. So on a regular diet, adults in general will eat anywhere from 10 to 20 grams of gluten a day, and children 5 to 15. And just to put grams into perspective of food, 1 slice of bread is around 3 grams of gluten. If you're going to talk about a gluten-free diet and how much gluten is allowed in such a diet, it's less than 20 parts per million, and that is 20 milligrams, not grams, 20 milligrams per kilogram of food. And that, as a visual, is about equal to these crumbs of a slice of wheat toast. This is from the Gluten-Free Watchdog site. So that is very little gluten that people can eat to safely keep bowel inflammation under control. Now, why do people even take or what are the reasons for a gluten challenge in celiac disease? Well, one is to make a diagnosis of celiac disease, and this occurs predominantly in those who already started a gluten-free diet or are eating reduced gluten before their diagnosis. So you can't, the biomarker, the serology, and the biopsy could be falsely negative if you're already on a gluten-free diet, or equivocal. If someone in the past has had an equivocal diagnosis where it doesn't fit together as a secure diagnosis of celiac disease, then those individuals may want to be challenged, because the gluten-free diet is a lifelong therapy as it stands now. And then there's research. So we still have much to understand about disease mechanisms that can help us understand more how to survey, or whether we mass screen or we do case finding, and to test the effectiveness of new therapies that are on the horizon. So clearly, this is a big part of research in celiac disease. Now, why do people even eat a gluten-free diet before they're diagnosed with celiac disease? And it's predominantly to reduce clinical symptoms. Either a family member has celiac disease and the patient says, well, I'm just going to try it and see how I do. But then after they try it, then they want to really know, do I really have this disease? Because it's difficult to follow the diet. And the diet is easy to try. You don't need a prescription from a doctor. You can just go on any site and learn what gluten is and how to exclude it from your diet. And when patients do go on the internet, they see that the symptoms of celiac disease are similar to theirs, and they say, let me try this diet. There are also physicians and extenders and healthcare extenders and family and friends who recommend, hey, try a gluten-free diet. You're having some digestive symptoms. It sounds like gluten causes a lot of trouble. Why don't you just try the diet? And again, they may get better, but then say, do I really have to do this my whole life? And then there's those who have a positive serology, and they may already be told you probably or likely have celiac disease. So they reduce their gluten intake waiting for this duodenal biopsy. And the waiting list to undergo an endoscopy is becoming longer and longer. So people are waiting months to get their biopsy, and they want to start feeling better. So they reduce the gluten, and that may interfere with the biopsy result. And then there's this perceived health benefit that gluten in general is just bad for us. And some take it, they read that it's a problem causing autoimmune diseases. They want to prevent those, or some read about the gluten effect, gluten causing neurologic symptoms. And if they have those symptoms or have a child with autism or other neurologic syndromes, they say, let's take gluten out of the diet. So what do we know about the studies about triggering celiac disease, active inflammation, or other biomarkers of inflammation with a gluten challenge? What do we know? So I'm going to separate and talk about some children's studies, and then I'll talk about adult studies. So in these children's studies, I just picked out 4 of the sort of maybe example studies. But they're all small, as you can see, except for the one out of Hungary. But if you look at the Mackey study, 29 patients, they were given 10 grams of gluten a day, which is almost what patients or people may eat in a regular diet, for a month, and then keep going even greater than 2 years. And they looked at, monitored either the clinical or serologic response, and then biopsied everyone after 2 years. And 100% had histologic relapse, but 4 of these patients, it required 2 years on that challenge in order to show a histologic response. In the study out of Hungary, 90 patients, these were patients who either had celiac disease and some didn't or weren't sure whether they had it. It was a 5 to 10 gram per day challenge, 3 weeks to 9 months. And then they looked at clinical or serologic relapse and biopsied all of them after 2 years. And 100% again had histologic relapse in the group who were diagnosed securely by an endomysial antibody and were given the diagnosis of celiac disease. In the home study, 10 patients, 14 grams a day, 1 month to 7 years. They looked only at histology at different time points, and 100% had a histologic relapse by 3 to 12 months. And then KERPA in 2008 looked only at 3 patients. They were looking at starting them back on a regular diet after remission and just following them real time for a clinical or histologic response. And there, 1 patient developed dermatitis herpetiformis after 16 years, 1 after 31 years, and 1 had DH and villus atrophy at age 34. So you can see it took years for some of these patients to relapse on a gluten diet, containing diet. And all of this there's very nice review by Pop et al. In 2023 that reviews all about the role of the gluten challenge in diagnosis. It's very nice review. Is celiac disease reliably triggered in adults? Is there any difference between adult and children? And there seems to be. So in a 205 Cornell study, these are all different countries, by the way. Leffler's the US and Sarna's the US, and most are Finland or Italy. 21 patients, these are with celiac disease. They got 13 grams a day of challenge, 2 weeks, looked at clinical or serologic response, and here only 38% developed symptoms, and there was no change in histology. But the caveat was only 1 of these patients, actually, even though they were deemed as inactive celiac disease, only 1 really had a truly normal duodenal biopsy. And I think others can address this in session 2. And then in other studies, 13 patients, this one 4 slices of bread for 3 days, only 30% had histologic relapse. In the Leffler study here, this was a double-blinded placebo-controlled trial. And again, this was normal histology, normal biopsy compared to control, because this was also a double-blinded study. But they gave 3 or 7.5 grams over 14 days. They looked at clinical, serologic, and histologic responses, and only 65% had histologic relapse. In the Sarna study, 47% had relapse at these lower amounts of gluten for 2 weeks. And in the Leonard study, who will be speaking later this afternoon, again, after 14 days with 3 or 10 grams, there was only a significant histologic response at the 10-gram dose. So as you can see, more from the adult study, it's somewhat variable who's going to respond to a gluten-free diet and how much, respond to a gluten challenge, and how much time is it going to take for them to respond. And this comes into our diagnostic dilemma. How long do we challenge for? And we want to make sure they either do or don't have celiac disease based on this challenge. So that in itself becomes a challenge. Do we have more sensitive biomarkers than histology to assess either the immune or tissue remodeling responses to a gluten challenge? And here there's studies going on looking at the IL-2 response. There's studies looking at the HLA-DQ gluten tetramers. There's studies looking more specifically at TTG-IgA tissue deposits on biopsy. And then there's 2 studies looking at genome-wide transcriptomic analysis of biopsies using RNA technology and tissue proteome analysis of differential protein expression. In other words, when you give someone a gluten challenge and you look at the sum total of expression of their proteins, either by RNA or by actual protein analysis, what goes up and what goes down, and can we use this as a more sensitive and reliable marker of a response to a gluten challenge? So this gets on to the topics for discussion today. The speakers who follow me are going to address, and the research part of this in session 2. How much gluten do we challenge with, and for how long, to make a diagnosis and to reliably determine in research studies whether drugs are going to be effective or not. Is a challenge in children different from adults? And what do we monitor after a gluten challenge in these studies to give us the best readout as to whether this is celiac disease or not celiac disease? And future directions that I view to limit harm, in other words, giving someone a gluten-free challenge can prompt symptoms. So we want to try to do this in the safest way possible. Are there more sensitive biomarkers that can limit either the dose or the time of the challenge? And can a gluten challenge actually be done in a test tube? Could we take a biopsy or blood and take it outside the body, put it in a test tube, and stimulate it there to show a response? And I'm looking forward to session 2 to address whether these will be future possibilities for patients with celiac disease. And in that, I'm going to turn the session over to the next speaker, and I'll be present at the end to answer any questions.
Thank you very much, Dr. Semrad. Fantastic overview, lots of information. And as everyone can hear, lots of questions, and hopefully, as I had said earlier, we'll have discussions. And thank you for the questions and answers. Keep it coming. We will address those in our panel discussion that happens after our next 2 speakers. Our next speaker, it's really my honor and pleasure to introduce Dr. Maureen Leonard, a friend and a colleague. She and Dr. Lebwohl will be talking about the diagnostics and the gluten challenge. Dr. Leonard will be speaking on the children, since she is the clinical director of the Center for Celiac Research and Treatment at Mass General Hospital for Children, and is an assistant professor of pediatrics at Harvard Medical School. Besides that, she has just a few other responsibilities, and I'm just going to talk about 2 of them. She is also the co-chair of the Celiac Disease Special Interest Group in our North American Society for Pediatric GI, Hepatology and Nutrition, called NASPGHAN, and she is the co-chair of that elite group. She also happens to be a member of the Executive Council of the Society for the Study of Celiac Disease, and that's the SSCD, and she's been a very valuable member of that Executive Council as well. So without further ado, Dr. Leonard, please educate us on the diagnostics and the gluten challenge in children. Thank you.
Thank you so much for that kind introduction. And all right, looks like my screen is shared. So yes, thank you for the invitation to speak about diagnostics and the gluten challenge in children. So I will mention these. I won't talk about these because there's currently no clinical trials in children, but I do work as a consultant or an investigator or co-investigator for a number of trials, all looking at therapeutics in patients with celiac disease. So today I will speak about reviewing some of the clinical situations for which a gluten challenge may be necessary in children. I'll describe the approach to conducting a gluten challenge and then also mention some special considerations in children. And I wanted to start with a case that we'll kind of talk through as we go through the next 20 minutes or so. So this is a patient who came to me, a 10-year-old male who came for a second opinion regarding whether he may have celiac disease. It was noted at his annual physical that he was having some epigastric abdominal pain, lack of weight gain, and poor appetite. His height was about the 30th percentile, weight was at the 5th percentile, but based on parental height, he was predicted to be closer to the 70th percentile for height. And so for these reasons, he had labs at his annual visit. It included a number of normal studies, but an elevated IgA TTG of 33. And we know that different labs have different cutoffs, so normal was less than 15 here. So the patient underwent an endoscopy, and the duodenal biopsies were shown to be normal, but a gluten-free diet was suggested due to the patient's symptoms, slow weight gain, and elevated TTG. So that brings us to, what is required for a diagnosis of celiac disease in children. So the diagnosis requires assessment of symptoms, serology, and the duodenal histology. So once we have confirmation that there's a normal serum total IgA level, in children, there are two ways to make a diagnosis. Diagnosis according to the North American guidelines involve obtaining an IgA TTG and obtaining an endoscopy that show with multiple duodenal biopsies. And if we see the characteristic changes of celiac disease, which include an increase in intraepithelial lymphocytes, crypt hyperplasia, and villus blunting, we can make a diagnosis. There's also a second pathway that is sometimes used, and that's a European pathway from these European guidelines that say, if the TTG is quite high, so greater than 10 times the upper limit of normal, and we have a second blood test at a different blood sample, which is an IgA anti-endomysial antibody test that's also positive, then we may be able to forgo the endoscopy and make a diagnosis of celiac disease in these patients. But regardless of the diagnostic pathway, it's extremely important that patients are eating a sufficient amount of gluten leading up to and during the testing process. And we heard already that sometimes patients or their families either decrease or remove gluten prior to completion of testing, either because they were told to remove gluten, maybe the wait to see a GI doctor was long, or they want to help, improve symptoms that they're having. So in these cases, the amount of gluten must be increased or reintroduced in order to perform accurate testing. So we heard, the reintroduction or increase in gluten is referred to as a gluten challenge. It's really defined as daily high dose gluten exposure, anywhere from 3 to 12 grams per day, with the aim of exacerbating disease activity. So what we expect to see with a gluten challenge is we expect to see gastrointestinal and or extraintestinal manifestations or symptoms or signs. Eventually, we expect to see some elevated serology if the patient has celiac disease, and we expect to see some changes in histology. We don't expect to see long-term complications from a short-term gluten challenge. We heard already some of the situations for which a gluten challenge is warranted, and this is the same for children. In addition to establishing or confirming a diagnosis of celiac disease, a gluten challenge is necessary to make a diagnosis of non-celiac gluten sensitivity. Ideally, a blinded placebo-controlled challenge is the standard to make a diagnosis for non-celiac gluten sensitivity, which I won't discuss today, but it's also needed if we have a patient with non-celiac gluten sensitivity to periodically reassess whether it's present, because it may be a transient condition, especially in children. And then in research, gluten challenges are utilized to, again, look at the pathogenesis of celiac disease, identify novel targets, and then establish proof of concept and examine efficacy when we're looking at novel interventions. But if we're speaking about clinical context for looking at a gluten challenge in children, in celiac disease specifically, there are a few sort of frequent clinical contexts in children for when it's really appropriate to proceed with a gluten challenge. And these include patients with a possible new diagnosis who don't meet that European criteria, so their TTG isn't high enough, and either they don't have a duodenal biopsy or their duodenal biopsy is normal, and they were already placed on a gluten-free or a gluten-reduced diet. We also see quite often patients that have symptoms when they're eating gluten, and yet we may not have celiac serology done or an endoscopy done, and they've gone on a gluten-free diet to help alleviate those symptoms. So we may see them again to try to confirm a diagnosis or rule out a diagnosis of celiac disease. And then finally, we have patients who have, again, that elevated serology, but a normal endoscopy. We're not sure if maybe they were eating enough gluten prior to their diagnostic workup, or they opted for a gluten-free diet without confirmation of their celiac disease. So again, those are patients that we would suggest perform a gluten challenge so that we can have a confirmed diagnosis. And before starting the gluten challenge, it's really important to assess symptoms, both that the patient is having at baseline currently and those related to gluten ingestion, either when they were eating gluten previously or if they're accidentally exposed to gluten intake, because they may have symptoms with that. We want to assess the current gluten intake. So that really requires a careful dietary assessment. Oftentimes we see patients in clinic that are eating gluten and they may not be aware of it because it's such a difficult diet to follow. There can be hidden malt or different hidden things in there. So assessing their current gluten intake is really important, because they may be eating some gluten daily, and that might be enough that we can do some testing. Of course, we want to review the previous workup and assess the gluten intake at that time. Were they already on a gluten-free diet? Were they on a regular diet? All of that is very helpful when we're looking at what's been done already and how helpful a gluten challenge will be. And then we want to consider HLA genetic testing. We know patients have to have either HLA DQ2 or DQ8 in order to develop celiac disease. If so, in patients, especially those with severe symptoms, those with, there's a lot of anxiety around potentially having to eat gluten again. So if this HLA testing is covered by insurance and is negative, it is helpful because we can avoid a gluten challenge if a patient doesn't have the compatible HLA genes, because they really have a very low to no risk of developing celiac disease. And then again, at baseline, you want to consider getting some baseline serology tests, maybe even before the gluten challenge. So you may have discovered that a patient on the gluten-free diet is actually eating gluten, or it might be helpful in a patient who maybe hasn't had testing but just recently removed gluten in the past week or two. So that can just be helpful to get a baseline. Elevated labs can be helpful, but negative labs really can't rule out celiac disease, especially in a patient with low or no gluten intake. So going back to our case for a minute, again, this patient is not feeling well, having slow weight gain, and their TTG is about twice the upper limit of normal, but they have a normal scope. So when we think about the diagnostic criteria for celiac disease, they don't meet either the European guidelines, because their TTG is not greater than 10 times the limit of the upper limit of normal. They didn't have that second IgA anti-endomysial antibody test. And they don't meet the North American criteria either, because they have a normal biopsy. So we didn't see any villus blunting or inflammation on the biopsy. And when they came to care, they were on a gluten-free diet for 6 months. So baseline serology at that point showed that the TTG that was tested once before was now normal. Thinking about their baseline assessment and asking questions, this patient was eating a regular diet at the time of labs and at the endoscopy. And it's important to really ask. Sometimes patients have to wait a couple months for an endoscopy, and so gluten can be reduced or removed separately between the time of the labs and the endoscopy. But this patient was eating gluten at both time periods. Despite being on a gluten-free diet for 6 months, they had the same symptoms of epigastric pain and lack of weight gain. And in review with our dietitian, we didn't find any known exposures to gluten. They didn't have any experiences where they know they were exposed and had any symptoms. So for all these reasons, we discussed moving forward with a gluten challenge. So early on, it's important to really discuss the goals of the challenge between the patient, for both the patient, the family, and the physician. So ideally, you want to talk about the gluten dose and the length, as well as the endpoint. So do you plan to monitor the serology for a while, or are you planning to book an endoscopy and see how things go? So those are all things that you want to discuss. You also want to discuss the timing of the gluten challenge. So it might be a good idea to avoid the holidays, or recently in my clinic, patients were happy to go on a gluten challenge prior to Halloween and have some different candy than they've had in years past. Especially in kids, we want to think about doing a gluten challenge over the summer. In school-age children, this can be a good time because if a patient does have symptoms or does have some difficulty concentrating, again, we can do it over the summer where it may not impact school. And then traveling can be a good idea or a bad idea. Again, really depends on how the patient is feeling. So if a patient isn't feeling well, then it's not a good time to do a gluten challenge while there's plans for big travel. In other cases, there may be going to a place where there, again, are different foods, or it may be even more difficult to be on a gluten-free diet. And so a gluten challenge during that time can be welcomed. So it's really needs to be personalized for a patient. And then there are some patients that really just can't do a gluten challenge. And those are patients that or that have to stop a gluten challenge really early on. So if a patient has severe symptoms that are interfering with their daily activities, such as severe abdominal pain, vomiting, or frequent diarrhea, and they're not able to attend, in our case, speaking about children's school or their other activities or socialize, then really that's not something that we can continue. So how do we monitor the response to a gluten challenge? And this is true for really kids and adults. So we assess symptoms. In the short term, those could be things like abdominal pain, nausea, and vomiting. Over time, we often see that those sort of subside, and we see more things like bloating, fatigue, and altered stooling. We can assess serology, so the IgA-TTG, but this can take quite some time to be elevated, and we'll review a little bit of the variability in the next slide. And then finally, looking at, the duodenal histology or the biopsies after gluten challenge. So the majority of studies are these research studies that require an endoscopy before you start the challenge and after the challenge. So you're comparing changes pre and post challenge in something called villus height to crypt depth ratio, which is measured here. That's not how we look at biopsies clinically. That's not what's looked at, again, clinically. So we really need, and we don't have pre and post endoscopies clinically often. So this is why our clinical approach to gluten challenge really has to be different than what we see in research studies. So clinically, we know there's great variability among how celiac patients present. Some have symptoms, some don't. The same is true for how they respond to a gluten challenge. And this is reflected in literature as well in terms of symptoms, serology, and histology. So this variability really leads to challenges in planning for and monitoring the response to the gluten challenge. So again, it really has to be a personalized approach. Patients may be asymptomatic with the gluten challenge, or they can have incapacitating symptoms. As we heard, serologic response can be sort of inconsistent. So this data is in adults, but really after a 2 to 6 week gluten challenge, the range of having a positive serology test in patients with celiac disease may be anywhere from 10 to 55%. And then histology is not, completely consistent either, even in the best conditions. Again, these are adult studies, but even in the best conditions, not everyone, we don't see changes in every patient, even at higher doses of gluten, but we can see that the higher the dose of gluten, and from other studies, the longer somebody is eating gluten, the more likely we are to see changes. So translating this research work to clinic is challenging. There's no standard approach for gluten dosing. The studies have variable doses, frequencies, and durations, as you saw. Many of the studies use gluten powder, which is important because in a research study, the dose must be precise, but it's not really palatable or exciting for someone who's going to start eating gluten again and might be worried about it to start eating some powder. We just review the data to say that serologies can be inconsistent post-challenge, especially in the early time period, but it can still serve as a guide to endoscopy. It's not necessarily the preferred endpoint. And then thinking about, the duodenal histology, we want to be mindful of not doing the procedure too early. It's invasive, it's time lost from school and work for parents and their families. We know that celiac disease can be patchy and it can be difficult to make a diagnosis. So being on a gluten challenge for a short period of time, it can be even more difficult. So again, as we've discussed clinically, we don't have that pre and post duodenal biopsy. So unlike research studies, we really need longer than a 2-week challenge to see some changes. So recently, a group of pediatric GI doctors sort of convened as part of this, this pediatric national group. And based on review of adult and pediatric literature, we suggested and published the following approach to gluten challenge for children. So we suggested that we should aim for 3 to 6 grams of gluten daily for 12 weeks, that there should be a patient provider check-in at 4 to 6 weeks to assess the symptoms and feasibility. And that can be through patient gateway or a visit, because if patients are having really tolerable or even no signs or symptoms, then they may we can increase gluten dosing. And we can extend looking at serology and even doing the endoscopy to, beyond 12 weeks in some cases. However, if a patient's having intolerable signs and symptoms, then we may need to reduce the gluten dose and think about doing the serology and endoscopy even closer to 6 weeks. As part of this recently published review, we also wanted to provide some more palatable vehicles for gluten, especially for kids. And since a clinical gluten challenge doesn't need to be as precise as those for clinical trials, we estimated gluten content in common foods children might eat or even adults might eat, so that you can give your patients more options than slices of bread. So we calculated different things like bagel, ramen noodles, brownies, which had a lot less than we all thought. And then we also looked at, we calculated how much gluten is in vital wheat gluten flour, which is what we used in research studies, and then baking or all natural or all purpose flour. So just to have some other options to know how much you're sort of recommending for your patients to eat. And this is busy, but as part of our review, we also created this algorithm. So this is really for providers. And while no single algorithm can account for all the possibilities of a gluten challenge, since it does need to be so personalized, we tried to cover quite a few different areas. I'll just focus on this area for the gluten challenge. So we really start by assessing the gluten intake and, again, reviewing previous workup and obtaining potentially baseline serologies. In patients that have a normal IgA level and a negative IgA TTG, we can consider performing HLA genetics in those that have positive genetics or unknown genetics, which is more commonly the case because it's not often or always covered by insurance. For those patients that have limited or no gluten intake for more than 2 weeks, then that's when we'd initiate the gluten challenge, ideally with at least 3 to 6 grams of gluten per day. We suggest the provider check-in to assess signs and symptoms and reassess the endpoints of the clinical challenge. And then for those that have tolerable or no signs or symptoms, we can increase maybe the gluten dose and increase the time period for the gluten challenge. And for those with, again, intolerable signs or symptoms, then we may need to reduce the dose. At that check-in, we want to, again, reassess the endpoints, assess how it's going, talk about whether we're going to do serology or endoscopy, and go from there. And if HLA is negative, then it's not likely to be celiac disease, and we can consider workup for other conditions. And then if you do find that the TTG is positive at your baseline assessment, then you can kind of go based on, if it's quite high, we can potentially use the European criteria or move forward with an endoscopy. If the TTG is not high and gluten has been restricted, then we want to increase gluten as we wait for the endoscopy to assess the diagnosis. So looking at special considerations for pediatrics, other groups have suggested no gluten challenge for children who are less than 5 years of age. However, we suggest an individualized approach. So for patients with normal growth and minimal symptoms, it's really safe at any age. Patients with poor weight gain who may not have had an improvement in growth on a gluten-free diet could also benefit at any age, because introducing gluten you may be able to introduce more high calorie, more palatable food. But for patients with poor growth or who've had improvement on the gluten-free diet, deferring the challenge after catch-up weight or after pubertal growth have occurred would be best. And then it's important to remember too that for children, there are risks of anesthesia, of course. So we want to make sure that we're doing a sufficient gluten challenge with both the gluten dose and length before doing an endoscopy. Ideally, the more gluten, the longer, the better. In the future, we'll hear about some biomarkers later that might help us get around this risk. So in the last year, I just want to mention both the American College of Gastroenterology and the European pediatric groups have, as part of larger publications, made recommendations for gluten challenge in children. These all differ slightly from what we suggested. The ACG recommends at least 3 grams of gluten a day for 2 to 8 weeks, and suggest performing serial serology, and if positive, moving towards endoscopy. The European group suggests a much higher dose of gluten for up to a year, and suggests, again, serial serology and an endoscopy based on the development of symptoms or positive serology. Well, we agree, and we wrote in our review that higher dosing and prolonged duration increases the diagnostic yield for children. We think 3 to 6 grams is an appropriate dose, and 12 weeks should still be a reliable endpoint while decreasing loss to follow-up. But again, the longer is better. The longer, the better. So just wrapping up, so what happened with our case? So again, with our patient who went on a gluten challenge, I did a typical check-in at 4 to 6 weeks, and they were enjoying their gluten with no worsening of symptoms. And so they were having a regular diet. We started Periactin or hyoscyamine, a medication for appetite and weight gain. And they were feeling well and had improved growth and symptom resolution. So after 6 months, we rechecked a TTG and it was normal. And again, growth continues to improve. So the plan is to check a TTG again, and then discuss either continued laboratory monitoring and the possibility of a future endoscopy, depending on if symptoms return, their growth, and if TTG comes back positive. But for now, they're growing and doing well with negative labs. So to wrap up, a gluten challenge is necessary for patients with an unconfirmed diagnosis of celiac disease or gluten sensitivity who haven't had a complete workup. An in-depth baseline to establish symptoms, gluten intake, and goals of the challenge is necessary. And in children, we recommend 3 to 6 grams of gluten daily for at least 12 weeks. And ideally a check-in around 4 to 6 weeks to sort of reassess those endpoints and how it's going. And there's really no definitive age or time in child development that a gluten challenge can't occur. So with that, I'll also be available at the end to discuss any questions. And I want to thank Dr. Verma and the many others that worked on this review, which is published in JPGN and is a guide to gluten challenge in children. Thank you.
Thank you very much, Dr. Leonard. Fantastic overview in terms of what to do for children. I think that children are special. We are both pediatric gastroenterologists, so children are very special to us, and they do have some challenges and differences, and we will invite you back on the panel in another half hour. We're going to move on with this session, and I'd love to invite Dr. Ben Lebwohl, who is the Associate Clinical Chief, Division of Digestive and Liver Diseases in the Department of Medicine at Columbia University, also the Director of Clinical Research at the Celiac Disease Center at Columbia University in New York, has a lot of different other hats as well, very interested in epidemiology and patterns of celiac disease, natural history, lots of things, but also the past president of the Society for the Study for Celiac Disease. So Dr. Lebwohl, educate us on diagnostics and the gluten challenge in adults.
Thank you, Dr. Verma, and to the organizers for having me. And thank you, Dr. Leonard, for really setting the stage on the pediatric side of things. I'm going to be presenting on diagnostics and the gluten challenge in adults. I should say that much of the well that we draw from, the pediatric and adult side, are really the same set of studies. You're not going to hear a lot of additional research informing this practice in terms of what we do in adults. It might be a little bit different. I agree with Dr. Leonard's general presentation in that there's a difference between the way things are measured and reported in research and what's done clinically. What's done clinically when you're in front of the patient has to be a sort of compromise between what we know and what might be logistically feasible. And so I'll be talking about how we do it at our center, what my own personal practice is, the data on which it's drawn, and some very recently presented original research that came out of our center, followed in the end by a short case. I should point out I've done a fair amount of advising to a lot of stakeholders who are interested in not only the expected outcomes in gluten challenge, but in using that to develop therapeutics for celiac disease, non-dietary therapeutics. And I also do work with the Food and Drug Administration that is very interested in celiac disease now that there are non-dietary therapies being tested. There are a number of reasons people come to a celiac disease center, specialty center. And I would say that our dietitian expertise is probably the most important thing. We like to talk about all the different offerings and expertise and research, but often it's access to our dietitians, which remain the mainstay for the treatment of celiac disease. We see patients who have non-responsive celiac disease, the rare patient with truly refractory celiac disease. We increasingly have patients who, for altruistic reasons, really want to get involved in research, which is terrific. But it's that last bullet, the uncertain diagnosis, that often is a reason someone will come to a celiac disease center. And that's when gluten challenge becomes a relevant topic to discuss. So this refers to the intentional introduction of gluten after a period of time that someone's already been on a gluten-free diet for the purpose of testing for celiac disease. This is a medically supervised challenge. And then we typically look at biopsy and or serology. And Dr. Leonard recently went through this, the literature on this, as did Dr. Semrad. But this seminal paper by Dan Leffler and colleagues, to me, illustrates a really important principle, which is that in general, histology during a gluten challenge starts to move first. Serology moves later. In other words, you'll more likely see something on a biopsy early on than you will on a blood test. And if you were going to use blood tests, serologies, TTG, and the secondary antibodies as part of your diagnostic decision-making, that's for the long game. If you're looking at histology, you can potentially take a peek shorter. So Dan Leffler's paper found that the majority of people with celiac disease will start to see significant declines in the villi on biopsy, even at 2 weeks. By 2 weeks, you'll see very little movement on serologies, on antibody testing. And so this is an important principle to keep in mind when facing a patient in front of you. So what about adults? Who benefits from or who wants a gluten challenge? Well, some general principles are shown here. Someone who started a gluten-free diet, maybe unsupervised, they tried it and they felt a little bit better, maybe substantially better, but now they're feeling ill again, and they want to know, was it gluten in the first place? Or maybe they're feeling good, but they want to know, how strict do I have to be? Can I eat gluten when I'm traveling, when I'm eating out occasionally, if it just causes some relatively mild symptoms? So a gluten challenge there is helpful. And sometimes patients will come where a healthcare practitioner said, go on a gluten-free diet because this celiac panel suggests celiac disease, or and it was never confirmed by a biopsy. Or I would call weak indications. Sometimes patients will come to us and say, my thyroid doctor told me to go on a gluten-free diet because I have autoimmune thyroid disease, and maybe a gluten-free diet will help that. That's one of these assertions that's out there with, I would say, zero or minimal evidence behind it. And yet it's something that it's repeated often enough that people believe is true, that a gluten-free diet is generally helpful for autoimmune thyroid disease. And then you have someone who's been avoiding gluten for years based on something, a very dubious statement. And now we have to figure out, do they really need to be on a gluten-free diet or not? And some of these patients really need to undergo a gluten challenge to figure that out. We're increasingly in the era of patient-driven testing. It used to be that it was small startup companies that were offering home testing for celiac disease, but now the big companies are involved. And so shown here is a patient ordered celiac disease antibody test. Patients can order and get it done without a physician prescription. And it's possible that because a physician was not involved in a testing, they might not be involved in the interpretation of the results, and a patient might start a gluten-free diet based on a serology result, and there might be uncertainty about that person's diagnosis, especially because no guidelines in the United States recommend for children or adults recommend a biopsy-free diagnosis. There's some movement about the pediatric groups adopting the European guidelines, but even in that case, for example, the American College of Gastroenterology, they don't recommend that. They suggest it, which is a weak sort of nod towards the fact that some people are moving towards a non-biopsy-based diagnosis. But even in that case, you really need to have a healthcare practitioner involved in that decision-making. So, these are people who would potentially benefit from a gluten challenge, but I don't always push it. I will encourage it when the diagnosis truly is questionable. So someone on a self-prescribed gluten-free diet, someone with borderline histology or serology, someone with seronegative celiac disease or reliance on IgG serologies, where there's really a question, what's happening here? Does this patient really have celiac disease? But it also requires a willing patient, a patient who would change their behavior based on the result of a gluten challenge. If a patient is coming in and they are intent on staying on a strict gluten-free diet for life, then you have to ask yourself, why are we going through a gluten challenge? If it's not gonna change the plan for long-term therapy and dietary adherence. But there are a lot of patients who would prefer to eat gluten if it is medically permissible, if it's advised as safe. And that's the kind of patient who'd really benefit from a gluten challenge, and in whom I would encourage it. So some common scenarios. There are certain sort of categories of patients who will wind up in a gluten challenge scenario. One is someone who cut out gluten because it was causing symptoms, most commonly bloating, maybe brain fog and other symptoms. But then they found that a few months later, it was corn, and then it was soy, and they're accumulating apparent food intolerances, but never had a proper test for celiac disease. And now they want to know, is gluten causing a problem, or does it have nothing to do with gluten? That patient might benefit from a gluten challenge. Sometimes we'll have an adult come in and say, when I was a kid, I was diagnosed with celiac disease, but I don't really have all the data there. I'm sure I didn't undergo a biopsy. I was told based on some blood tests, those blood tests are long lost. My parents don't have them. And then I've been eating gluten a little bit and I didn't get too sick. Do I really need to be on a gluten-free diet? That's a very common situation. And if you think about, what led to that, that I would say is an argument for continuing to rely on healthcare guided diagnoses of celiac disease, including a biopsy among children. Or there might be someone who was told, I think you got celiac disease and you should be on a gluten-free diet, but we shouldn't do a biopsy right now. Maybe because it's just not feasible. They're traveling, they're moving around, or they're pregnant, and we think that that going through an endoscopy with a biopsy might not be advisable during pregnancy, but continuing gluten during pregnancy also might not be advisable. Dr. Leonard said there's really never a time or an age at which a gluten challenge is contraindicated. I would say in adults, pregnancy is a situation where we really want to potentially put that off. Another very common scenario is you have someone, let's say, a mother of a celiac child who is not eating a lot of gluten because the house is mostly gluten-free, and she gets screened and she has a weak positive antibody, and then has a biopsy and it's read as normal. And maybe it's because she wasn't eating much gluten. And so that's another common scenario where we might consider a gluten challenge. But there are also scenarios where I do not encourage a gluten challenge. If I am concerned that these patients will get severely ill. There are some people who wind up in the emergency department after significant gluten exposures. These patients are not good candidates for a gluten challenge if they're going to get so sick. There are also some people who, even if I don't know they're going to get very sick, I just don't advise it because of their individual circumstances. There's some people with suspected gluten ataxia, balance issues, or severe neurological reactions to gluten. And in those people, we're less sure that the introduction of high dose of gluten will only cause transient symptoms. We're worried about reversibility. And so I don't push it in that situation. Someone who gets headaches and brain fog, that doesn't fit in that category. Those patients might benefit from a gluten challenge, and we talk about whether we think they tolerate it. Pregnancy is another situation where I typically say, we're not doing a gluten challenge now. We're not going to be doing an endoscopy while you're pregnant, and we're not going to be exposing you to gluten during that situation. Let's do it another time. I do encourage people to figure it out, though. There are people who are on a long-term gluten-free diet, and to not know their celiac status can potentially obscure other diagnoses. Anna Tavakoli, who is a trainee at Columbia when she did this study nearly 10 years ago, looked at patients at Columbia who were found not to have celiac disease, but had been on a gluten-free diet for presumed non-celiac gluten sensitivity. It turns out that even non-celiac gluten sensitivity is not always the answer. And about 30% of such patients who didn't have celiac disease and thought it was gluten causing a problem, we found something else when they underwent a full workup, whether it was additional food intolerances, microscopic colitis, small intestinal bacterial overgrowth, gastroparesis. There is benefit in being curious about what's causing someone's symptoms and just leaving it be because gluten seems to be a culprit might obscure another diagnosis. So I want to talk briefly about a study that we did really looking at the Columbia experience in terms of what happens after a gluten challenge. What do we find? We wanted to answer a simple question. Among people on a gluten-free diet, uncertain if they have celiac disease, who are willing and able to have a gluten challenge, what proportion end up having celiac disease when they undergo the challenge? This is the kind of research we call like news you can use. We did this analysis because we want to be able to tell patients who are coming in thinking about a gluten challenge, we want to answer a question, what's the chance this person has celiac disease? And so we evaluated records of patients who came to our center who underwent a gluten challenge followed by an endoscopy with a biopsy of the small intestine. And everyone who was having that gluten challenge, we did not know if they had celiac disease at the time of their biopsy. This was really a diagnostic test so as to figure out if they have celiac disease or not. This was led by Dr. Martin Ventoso, a trainee at Columbia, and was done in collaboration with our center providers. The primary outcome was celiac disease as defined by villus atrophy on duodenal biopsy. So we used the histologic diagnosis. We identified 206 individuals who did not have a known celiac disease status and reintroduced gluten and underwent a biopsy of their small intestine. And the top line result, what percentage ended up having celiac disease or villus atrophy on their gluten challenge, was 30 out of 206, 14.5%. So we can now tell patients who are coming in who are considering having a gluten challenge and then having the biopsy, most people on that biopsy don't have villus atrophy, don't have a confirmed diagnosis of celiac disease, but about 15% do. We then looked at, is there a predictor of being more likely to end up having celiac disease or having villus atrophy on your biopsy? Can we predict who's at higher chance of having celiac disease? We didn't find a lot of predictors. When we looked at age among adults, when we looked at gender, there were no differences. We did find a couple things. First of all, having gastrointestinal symptoms as the reason for adopting the gluten-free diet and developing them during your gluten challenge was not predictive of having celiac disease. Now, this might be counterintuitive, but as you likely know, celiac disease can cause all sorts of different symptoms and sometimes none at all. Often these symptoms or signs are outside of the intestine. But for people who report that when they're eating gluten, they get more abdominal pain or other symptoms like that, that did not increase the chance that celiac disease was going to be present. In fact, if you look at bloating, people who during the challenge reported that they felt bloating were going to more likely end up not have celiac disease when push comes to shove, when you have the biopsy. So bloating during a gluten challenge or bloating as the reason for eliminating gluten is a reverse predictor. It's less likely to mean celiac disease. When we looked at laboratory values, the only predictor of being more likely to have celiac disease was having any blood test related to celiac disease in your past that was positive to any degree. So if someone is having a gluten challenge now, if they've ever had a positive either Gluten or TTG in the past, you're more likely to end up finding villus atrophy on that gluten challenge. So the main findings were about 15% of people on a self-prescribed gluten-free diet end up having biopsy-proven celiac disease after gluten challenge. Age and gender did not impact this. Any positive serology increased the chance. Symptoms did not increase this probability. Bloating even decreased this probability. This, I would say, underscores the idea that we really should not overly rely on the experience of bloating or pain during gluten exposure in terms of our calculus of does this person have celiac disease. Doesn't mean that symptoms are unimportant. Symptoms are extremely important. We are trying to help our patients feel better, but we should not be using the symptoms in our calculus of, oh, I think this patient likely has celiac disease because they get sick when they eat gluten, because it actually is the opposite. It's celiac disease can cause many different kinds of symptoms, including no symptoms, and the presence of symptoms during a gluten challenge does not increase the chance that that person has celiac disease. So just some practical considerations. Maureen Leonard went through the different ranges. What I recommend is it can't be less than 2 slices of bread a day. When we did our own measurement of how much gluten was in a slice of Arnold's whole wheat bread, it was 2.5 grams. We sent that to Biodiagnostics as part of a research study. So we say that's about 5 grams a day. And what I tell patients, if they're going to be doing that and they haven't been eating gluten for a long time and we're worried about symptoms, I say don't start this all at once. Ramp it up. Joe Murray from Mayo Clinic suggests if we're worried about severe symptoms, start with 1/4 of a slice of bread on the first day, and then double it each day. So day 1, 1/4 of a slice. Day 2, half a slice of bread. Day 3, full slice of bread. And day 4, 2 slices of bread. And then you can continue to ramp up if they tolerate it and how they're feeling. But that might decrease the chance that you'll have to cancel the gluten challenge because of severe symptoms. The duration should not be less than 2 weeks. And I typically tell patients at least 3 weeks. And in terms of the actual biopsy, you need to biopsy the duodenal bulb in addition to the second portion of the duodenum. There are a lot of people who have only limited villus atrophy, and it can be patchy. And you don't want to miss it when you're doing a gluten challenge, especially a shorter duration gluten challenge. So you need to take at least 6 specimens in total and include the duodenal bulb. The incorporation of serologies, or these antibodies in a gluten challenge, I would say will vary depending on the individual circumstance. We like to rely on a biopsy for the diagnosis of celiac disease, but serologies can be helpful. First of all, they help corroborate, especially if the biopsy is very patchy or subtle. Second, serologies take longer to appear. And sometimes if you have a borderline histology after a gluten challenge, continuing to eat gluten and doing serologies might help work as a tiebreaker. I would say that, at least in my opinion and our center's experience, biopsy remains central in terms of its role in a gluten challenge. Another just practical consideration is if it's possible to make this a good experience, we should try to do this. What that means is, unlike in certain clinical trials where people are drinking a slurry, if people want to eat cookies and other pleasurable things during the gluten challenge, that should be acceptable, with a caveat. You need to be careful, and particularly, this is a Chicago conference, and you think about these deep dish pizzas. I do not encourage a patient who's going to start a gluten challenge to immediately go for the deep dish pizza, for a couple of reasons. There's a lot of gluten in that. There's also a lot of other stuff in that. And if symptoms are part of the reasons that someone was concerned about gluten in the first place, there's a lot of fat, there's a lot of dairy, there's a lot of tomato in a deep dish pizza. And so someone might feel pretty ill after having a deep dish pizza after being strictly gluten-free for years. And it might have nothing to do with celiac disease, or even an immune response. It could be bad reflux, or it could be the fact that fat is the hardest of all the macronutrients to digest, or it could be that there's some degree of lactose intolerance. So, I try to make this as pleasurable an experience as possible, but I tell people, don't immediately jump for the pizza. So just briefly, a case in the last couple of minutes. 44-year-old woman had several months of fatigue and had celiac testing because she got a family history. TTG-IgA was 1 point elevated, 4. Upper limit of normal was 3. And she hasn't been eating a lot of gluten because she lives with a child with celiac disease. This is a very common scenario. She got genotyped and DQ8 was present, so she has a celiac compatible gene. And she ramped up her gluten ingestion to nearly every day for 4 weeks and had an endoscopy. And the endoscopy with biopsy showed increased intraepithelial lymphocytes and normal villi, and then had another round of testing after 4 weeks. And now TTG was negative, deamidaglutine peptides were negative. And then she came to our center asking for my opinion, do I have celiac disease? So all this happened. She had undergone a gluten challenge, and had basically a normal or borderline biopsy, and the blood work was minimally elevated and not elevated. So the initial impression was that this was a minimally elevated TTG-IgA. It didn't rise further after you increase the gluten. Pathology, not quite normal, but not diagnostic either. So my recommendation was, let's repeat blood work now, because she's still eating gluten, and now it's been 3 months. And let's look at your slides, because maybe there were some subtle changes. And if there's no diagnosis based on above, we can do another gluten challenge. This time it'll be a higher dose, and this time it'll be a longer duration, 8 weeks. That day, she had a repeat TTG-IgA, and now it was 35. Now the units of measurement were different, and sometimes this can be a cause of frustration because labs can use different cutoffs. But her TTG, which was minimally elevated and then normal, now, after a few months of eating gluten, was rising. And we got the slides. And in fact, the second portion of the duodenum showed increased intraepithelial lymphocytes with normal villi, so not clearly diagnostic, but the duodenal bulb showed partial villus atrophy. And so the impression at this point was that she actually has ultra short celiac disease, which is celiac disease confined to the first portion of the duodenum. And this patient did not need a repeat or prolonged gluten challenge. And point to bringing up this case is a gluten challenge can sometimes be crucial, but sometimes reviewing data that's already out there, having a second set of eyes, particularly an expert pathologist, or collecting more non-invasive data like antibodies after a longer period on a gluten-containing diet can help you make the diagnosis without having to go ahead with another gluten challenge. So this can be offered to clear up diagnostic uncertainty, and there are multiple protocols for challenges in the literature. You need to balance the sensitivity, in other words, your ability to pick up celiac disease, with tolerability and logistics. But sometimes review of previously collected data makes a gluten challenge unnecessary. With that, I thank you for your attention and looking forward to the Q&A.
Thank you so much, Dr. Lebwall. I was sad to hear about the deep dish pizza for a gluten challenge, but I would love at this moment if we could invite all of our speakers from this morning. So Dr. Semrad, Dr. Leonard, Dr. Verma, and Dr. Jabri. I would love Dr. Jabri and Dr. Verma will lead our panel discussion this morning with our speakers, but I want to thank everyone. This was really informative, and I want to encourage you to please utilize the Q&A function to, as we are even within this discussion, put your questions in there and we will absolutely get to them. And one last housekeeping note. Once this panel discussion concludes, we will go to a break, and within the schedule on the website, you will then link to our second session. I'll come back with further announcements, but I just wanted to remind everyone that we will be taking a short break after this panel discussion. So Dr. Verma and Dr. Jabri, I'm going to turn it over to you.
Thanks, Rachel. What a session. Thank you so much. I think there's a lot of fun stuff, a lot of good stuff, and a lot of questions. So thank you very much, all three of you, Drs. Semrad, Leonard, and Lebwall. As I was kind of going through the questions in the Q&A and thinking about it, perhaps one of the things that we could start off is from the diagnosis itself. I know each one of you has talked about different antibodies and so on, and I think there were some questions about recombinant TTG versus regular TTG. What are the differences, and what is the blood test that you would recommend as we start the diagnostic process? So maybe we'll go pediatrics first and then go with the adults. So what would you recommend, and your thoughts about the differences between regular and recombinant TTG? Dr. Leonard.
So we do recommend that there should be a total IgA level done at least, once. And then if that is done and is within the normal range or at least above 7 to 10, then we can use the IgA and TTG. And then regarding the TTG, I know that, there are many different assays that are used. Some look at TTG alone, some combine, some DGP, and then we also there are panels that look at a number of different tests. So what we typically use and what we recommend is just the IgA TTG without addition of other tests, unless somebody has an IgA level that is less than 10 or so, in which case we would recommend looking at the IgG deamidated gliadin peptide test.
So if those antibodies are elevated, so long as the IgA is normal, you move on and say, okay, an endoscopy needs to be done. In the adult world, for the adults, Dr. Lebwall.
So very similar. This specific question about recombinant versus regular, I think that just speaks to the assay and the development of how the antibody is actually synthesized, and that should not matter in terms of how accurate it will be, both in terms of sensitivity, your ability to pick up celiac disease when you're not sure if a patient has celiac disease, and specificity, your ability to discern someone with true celiac disease from someone without celiac disease. General principles are the same. TTG IgA is the desert island test. That's the one that you rely on. But it's not going to be accurate if the patient has unmeasurable total IgA. If they're IgA deficient, then you have to rely on IgG serologies to some degree. And that's what the guidelines all say. I would say there's always an asterisk. And I would venture to say this may apply to children as well as adults, but I think it's been studied in adults more. These deamidated gliadin peptide antibodies are out there. I do believe there are some people who have celiac disease and they only make that. They have a deamidated gliadin peptide IgA, and then you biopsy them and they have villus atrophy, even if they had a negative TTG. This is not a common condition, but we have a handful of patients, at least in our center, who are diagnosed using that. By far the most common thing is that people make the other error, which is they look at those other antibodies, they assume it's celiac based on that, they go gluten-free, and that's almost always a bad idea because they don't have celiac disease. But every now and then, their patients will have isolated gliadin peptide IgAs that will have villus atrophy. This has not made its way into guidelines, but sometimes we do make those exceptional diagnoses.
So you would say it's very important that whenever any testing is done, it's actually a discussion with an experienced gastroenterologist. Primary care has so many other things to learn about. So really important from a patient standpoint and from clinicians who don't necessarily work in the celiac world to, if you have a question, call your friendly gastroenterologist. Dr. Semrad, your view about doing the genetic testing?
Well, just to segue into Dr. Lebwell's response, yes, the TTG IgA and the total IgA I use as well, but also there was a question in the question answer box about, can you have a positive TTG IgA antibody without carrying the genes that pose the risk for celiac disease? And the answer is yes. Particularly at low titers, which is the key here, the TTG IgA antibody can be found in other inflammatory conditions. And this is why we're so adamant about getting biopsies when that TTG IgA level is equivocal or low or weak positive. It's key to get that biopsy because that does not mean celiac disease the same as if it's tenfold positive. The correlation with villus atrophy is not good in the weak positive patients. So I rely on that. In terms of genetic testing, I tend to save it for people who are either family members that want to know their risk or people where there's an equivocal diagnosis. And because the genes are not diagnostic genes, and sometimes we get patients who are diagnosed because they had a positive genetic celiac risk gene. And that, of course, is completely a patient who does not necessarily have the diagnosis. So I use the genetic testing. There is still some fear about genetic testing and that being held against patients for their insurance and for other things in their life. And I'm surprised by this because I thought there's a federal law against that now, but people don't believe the government that much in these days. And so some are still skeptical how in a child or that genetic test may be used against them in some kind of way. So some people don't want genetic testing.
And I think that again goes back to a discussion with your clinical team in terms of when to do the genetic testing. And having a positive genetic test does not mean you start on a gluten-free diet. But I think that really starts off all these discussions about going on a gluten-free diet and then having to come back and see people and figure out, do you really have celiac disease or not? And that goes into the whole challenge in terms of when do you do challenge or not. I will ask Dr. Jabri if she has a question. I have a few more that I would like to ask, but I do want to have Dr. Jabri ask her questions as well to the panel.
Thank you, Ritu. I just want to say one point. It is true that sometimes for very low antibody levels, there's a question, but I would still like to emphasize that anti-transglutaminase antibodies are a hallmark of celiac disease. When they're at very low levels, the specificity of the test may be in question. And there could be a discussion about the fact that one may develop anti-transglutaminase antibodies of a different type. And in that case, the anti-endomysium would be negative in certain viral infections. But that remains to be shown. But I think for everybody listening here, anti-transglutaminase antibodies is part of a diagnosis of celiac disease. I just want to be very clear about that. And gluten-sensitive patients who are not celiacs will not have anti-TG2 antibodies. I just wanted to be very clear about that. Concerning the question, I think one important question, Ben, for instance, has alluded to it, I think is there a danger to a gluten challenge? And I think this is still a very important question to ask. And Ben, one of the questions was, can one develop lymphoma after a gluten challenge? So I think this is a very important question to answer. And are there dangers? You evoked ataxia as maybe one of the only ones where one should avoid it, and then pregnancy. But I really would like you to, re-put in context whether there is or not a danger for a gluten challenge, and whether, lymphoma is a risk.
Thanks, Bana. So first of all, just to be clear, there's no increased risk of lymphoma in the long term after a short-term gluten challenge. That should be very clear. Lymphoma is out there as a specter and something that we think about and talk about because people with untreated celiac disease do have an increased risk in the long term of lymphoma. It's one of the reasons why we try to make the diagnosis of celiac disease and why we encourage strict gluten avoidance so as to encourage mucosal healing for long-term risk. People with celiac disease who then heal because they've gone on a gluten-free diet no longer have an increased risk of lymphoma compared to the general population. So that I think is just very important to know. That said, there are people who get very sick when they get exposed to gluten. And so we're talking short-term. These are people who, when they get gluten, they miss work or school. These are people who maybe a gluten challenge isn't in the cards, because they might get so sick that they would have to miss work or school for days or even weeks. And that's not something that we'd be willing to put people through. First, do no harm. And it's something that patients likely wouldn't accept. Those are short term. The neurological question is very specific to the question of ataxia, someone who has some evidence where they have a cerebellar problem with balance and coordination from gluten, that we're very much cautious to intentionally give someone gluten for diagnostic purposes. That is extremely rare. I've only encountered a small handful of patients in my career thus far. Migraine headaches, brain fog, and just not feeling quite right is not that. That's much more common. And sometimes during a gluten challenge, people can tolerate that and sort of push through that. But ataxia, if a neurologist has told you you have gluten ataxia, generally we don't push a gluten challenge.
I just wanted to make one other point about that. In the study that we published in 2021, when we did a 2-week gluten challenge in adults, part of that study involved doing a video capsule endoscopy about a month after that 2-week gluten challenge. And what we saw is that in all but one patient, the damage that was seen during the 2-week gluten challenge had resolved. So we feel, at least, based on that literature, and although it's a small population, confident that the damage that was induced during the clinical trial gluten challenge 2-week period, it resolved within a month based on the video capsule endoscopy. And the other piece I'll just mention is, you saw in the Q&A too, that when they ask about whether somebody with negative HLA genetics can have a positive TTG, it is important that you have a gastroenterologist and maybe specialist in celiac disease review that HLA report, because again, we know that some of them that you can order online don't test for all of the genetics that are compatible with celiac disease. There are some areas or some different groups that report the allele, so you can see whether somebody has half of a DQ2 or half of a DQ8. So it is important that you review the genetics with usually a celiac specialist, because it might be reported that you have negative genes, but you might actually have a piece or another more rare genetic compatibility.
The point that Maureen made is very important. And indeed, you can have a celiac disease with just part of the predisposing genes, and that requires more sophisticated analysis. So it's very, wise advice to, once you have something that doesn't make sense, go and see a gastroenterologist who is an expert in celiac disease. Carol, any additional input you would like to give?
Oh, no, but I would like to answer one of these questions in the chat. Yeah. Many patients continuously have low amount of gluten exposure at restaurants, friends' homes. They state no symptoms, so okay, question mark. And the answer to that is the slide I put up at 100 milligrams of gluten, which is 200 milligrams of gluten. Those patients all no symptoms, but they definitely had histologic changes. So their intestine can be inflamed, but they don't necessarily have symptoms. So the question is always, for quality of life, how strict do we want our patients to be? And the answer is strict enough so that they recover from villus atrophy. On-intestinal biopsy is now the gold standard for recovery on a gluten-free diet. So I think while you don't have symptoms, it still may not mean it's safe for you in the long term. And Dr. Lebwohl put out a paper about long-term consequences of villus atrophy in a study, and maybe he can comment on that. So the answer to that is you may not be okay.
Yeah, sorry, go ahead, Ban.
Just regarding that point, Carol, I think a very important point that all of you have made is that there's a whole spectrum of response to gluten. You have individuals who with tiny amounts of gluten, like 100 milligrams, will have major clinical symptoms. You have others who will have no clinical symptoms whatsoever when they have severe villus atrophy. And you have patients who can eat gluten, seem okay, and then when you look at their bone density, they have actually major osteoporosis. So I think it's very important to keep in mind that there is this large spectrum, and so this, and then I'll let Ritu continue the panel, but this gets me to the other question I wanted you to emphasize, which is the spectrum of symptoms and villus atrophy. I find it very intriguing, and we'll go in the research session about how we can use that to get insights into pathogenesis. But there's around 50% of patients who will develop villus atrophy after 6 weeks of 6 grams of gluten challenge, meaning 50% don't. So what do you think about that, and how does this impact the usage of gluten challenge as a diagnostic for you?
And I think before anyone answers, there is a question in the Q&A about a patient who responded well to a gluten challenge, not having any symptoms, and would you just recommend they continue on a normal diet and not worry about it again? So I think it all sort of goes along with that. So perhaps, Ben, you can tell us a little bit about the study that was published with long-term complications. There's also a question for you about the ultra-short celiac, so maybe sort of talking through these points.
Sure. I mean, a lot to unpack, but I'll try to be brief. One of these overarching questions is, how strict do I have to be? And, this is a more complicated matter than giving out a sheet of helpful information, because this has to be individualized. We know about potential hidden sources of gluten when eating out, and we talk about soy sauce and others, and French fries, etc. Ultimately, though, this has to be individualized to the person, and that's the role of assessing symptoms, serologies, blood tests, and a follow-up biopsy. Because there are some people who, they have a certain practice and then they feel fine, and we biopsy them and they've healed, and we say, keep doing what you're doing because your current practices seem to be sufficient. And then there are other people who might have very similar behaviors, and they have ongoing inflammation and villus atrophy on their biopsy. And we say, you're more sensitive. Whether you feel it or not, you're more sensitive. So we have to rely not just on symptoms, but on those markers. That said, soy sauce, gluten in soy sauce is not enough for a gluten challenge. right? So there's where you see gluten in terms of monitoring, and then there's the kind of gluten that someone really has to take in order to bring out celiac disease, so we can say with reasonable confidence whether they have it or not. Ultra short celiac refers to celiac disease that's only visible on a biopsy of the very first part of the duodenum, the so-called duodenal bulb. This is something that 15 years ago was not routinely looked at. We only relatively recently discovered that you can have such patchy celiac, and that maybe the canary in the coal mine, or just the very beginning of celiac disease, can be seen in that part of the duodenum. People with that condition tend to be younger, tend to have fewer symptoms, tend to have lower T2G antibodies. So we believe it's a more subtle form of the condition, but we're still advising strict gluten avoidance once we find it.
Thank you. And Maureen, anything from the pediatric end, as we talk about, the low gluten that people get in their diet, there's asymptomatic, silent, and again, that's a whole definition on its own. And perhaps you can reflect a little bit about what silent celiac disease really means. Is it really silent, or there's something that we don't know? And what is it in the pediatric world that someone should be concerned about?
Yeah, so I mean, I get this question a lot in clinic. It is okay if I have something here and there. And in pediatrics, we're very concerned, obviously, about growth. So we know that there's a specific period of time, right, where children can attain their expected growth. And so we really focus on minimizing any, accidental or purposeful gluten ingestion, because whether they have symptoms or not, we don't know exactly how their intestine is responding, and we want to make sure, or like others have said, bones and other things. We think so much of bone growth is, and bone density is attained in the childhood years. So it's really important to really minimize gluten exposure in childhood, so that we can, again, focus on growth and having strong bones. I will say there's a question in there too, just mentioning, children are different sizes, different weights. And so we kind of have been talking about a general, try to have 3 to 6 grams or even more if you're doing a gluten challenge in children. And what if they are, if we're talking about a 2-year-old, that may be a lot of gluten. So we discussed this sort of in our national group, but we don't really have the data to suggest, certain amounts of gluten per kilo, which is what we do with medications in pediatrics. So we just have to focus on, trying to get a serving in there. But the question is a good question, but I don't think we have the data yet to say how much a child would need based on weight.
So even if there are no obvious symptoms like belly aches and diarrhea or anything like that, that's the caution that one has to stay on a gluten-free diet. Because again, there are so many other symptoms that we don't think that we have any symptoms. Obviously, you go on a gluten-free diet, the headaches go away. So that could have been your symptom or something like that. So I think having a detailed history would be important. And I know in terms of the gluten challenge, so Ben, I'm the meanie. I usually tell my patients, don't go back and eat a regular slice of bread, only because, I feel that the challenge, if you do the challenge and it's that 6, 8, 12 weeks and you start eating regular bread, to then ask someone to go back on a gluten-free bread, in my mind, is cruel. So I don't send them to that deep dish pizza for other reasons as well, in terms of the challenge. So again, it becomes very individualized. I mean, I have patients who tell me, I don't care if I have to go back, I'm going to go eat the regular stuff for the challenge. And Maureen, from your standpoint, you mentioned about growth and having a concern in pediatrics. But if you were to do a short-term challenge, and I know you talked about the timing of the challenge, would you say that from a pediatric standpoint, if there was a challenge that's needed, and I know we do it very often based on conflicting reports from the serology and the biopsies, would you have concerns if someone was to do a challenge in that 6, 8, 12 weeks?
So again, it really depends on the person and sort of the case that I discussed. So we may see somebody on a gluten-free diet and they haven't had any improvement in their growth or their symptoms, and that is a person who, it doesn't, to me, even if they're, in that pubertal growth spurt, that it's important to still do the challenge, because they may have a greater variety of foods that they can enjoy, and that might help increase their weight. But again, if it's somebody who is on a gluten-free diet and we don't have a clear diagnosis, but they are now growing well, then that is somebody that I would probably wait until we are further out and do a gluten challenge in the future, so that we don't possibly impact their growth. So it really depends on the child and their symptoms.
And does it matter how long someone has been on a gluten-free diet? So if, and both from a pediatric and adult standpoint, if you have somebody who comes in who's been on a gluten-free diet, let's say for 2 months, and now wants to really know, do I have celiac disease or not? Their serology is questionable, biopsies are questionable. Would you do a different length of gluten challenge versus someone who's been on a gluten-free diet for 2 years? Would you modify that? Ben, what would you say?
I don't put that into my calculus in terms of my recommended duration, but what I do let it color is my expectation of how sick someone might get. As a general principle, if someone's been strictly gluten-free for a very long period of time, there is a greater chance that they'll be more sensitized to gluten exposure. Whereas if it's a relatively recent adoption of a gluten-free diet, it's unlikely they'd get super sick when they start to eat gluten again. So there, it's just more management of expectations and how to ramp up the gluten challenge.
Yeah, if I
Carol?
something there.
Fun.
I think there's a complexity there that people not always understand, and that the Immusanti trial, has really put forward. The symptoms the clinical symptoms that you experience after a first gluten challenge have nothing to do with villus atrophy. They have to do with the acute immune activation that you're experiencing. And actually what the mechanisms are for those symptoms is still something we need to understand. So those symptoms do not equate with villus atrophy. And so I would say somebody who has been on a gluten-free diet for a long time, yes, will experience more acute, has a higher chance of responding with symptoms. But somebody who has been on a gluten-free diet for a short time will probably develop villus atrophy earlier than somebody who hasn't. But no studies have been done to really assess that. And I think because of that, it's important to keep the classical way of doing it, because if not, we will never understand and we will not have a clear diagnosis pathway. But from a mechanistic point of view, one could predict that probably somebody who has been on a short-term gluten-free diet will develop villus atrophy earlier, just because their pool of aggressive T cells is smaller than the pool of somebody who, like when you just had an infection or a vaccination, your pool of immune cells is higher, has a higher number than when you have waited a long time after. So, I think it's very important here for people listening to us that we differentiate acute symptoms from villus atrophy and tissue damage. And that's why I think many of us don't believe that there is any real danger for a gluten challenge, because it doesn't equate with severe tissue damage, and it's only a transient tissue damage, as Maureen has stated. So I just wanted to clarify that, because I feel this is often a confusion in the mind of people.
So standardizing it would be good. But Carol, in your clinical practice, what do you differentiate between someone who's been on a gluten-free diet forever versus someone who just went on a gluten-free diet to challenge?
No, I use the same challenge. The only thing is, if it's a month, I just go ahead and biopsy, and maybe the inflammatory lesion is milder looking by then, but it's enough to make a diagnosis. So I'll try to do that if I can, but if not, I'll just put them on a full challenge. But the other thing I just want to see in this question and answer, someone that said, can someone that has Crohn's disease do a gluten challenge? Can it make the Crohn's disease get worse? And this gets back to the, use of the gluten-free diet in so many other conditions to control symptoms. So in many other diseases, not celiac disease, people are going to the gluten-free diet to control their GI symptoms. And the answer to that is some people can have both celiac and Crohn's disease. So the question is, why did you go on a gluten-free diet? And, you know, if you're trying to figure out if you have celiac disease and Crohn's, then you can have a challenge. Maybe Bana can address this. I don't think it has any impact on the Crohn's disease. So just to do that. And there's another question about someone who has just a deaminated IgG antibody, and IgA is normal, everything else in their biopsy is normal. I look at these Gluten antibodies a little differently because it's a food antigen, and we often sample food antigens. So those antibodies can be positive because it's an antibody to a food antigen that you were eating. So I think it's a little hard sometimes to use that IgG, particularly the IgG deaminated gliadin, unless you're IgA deficient. Then of course that takes on a different spectrum. But these antibodies can float around for a while, and doesn't mean you have it or you have a risk, and genetic testing may help you in that case.
But in that case, would you do an endoscopy?
It depends on symptoms, family history, and suspicion, you know, but I think in the end, the duodenal biopsy becomes very important at resolving. If someone's really concerned and you don't know, and there's any antibody positive that's connected with celiac disease, then I think you have to go to the tissue level and find out whether they have it or not, and then know the answer. Because otherwise people struggle, do I, don't I, do I, don't I? And then they don't want to necessarily stay gluten-free for life. They just want to know. And so sometimes the genetic test can get you off the hook, but it's a common gene, the DQ2 and DQ8, they're common genes. So a lot of people carry them, but don't have celiac disease.
Again, I want to re-clarify one point, which is having antibodies, as you said, Carol, against gluten can happen in many disorders. But transglutaminase activation is something that's much more specific to celiac disease. So anti-gluten IgG or IgA antibody are way less specific than IgG anti-deamidated gluten peptides, because there you have transglutaminase activation. So again, I just want to clarify for the people listening to us, having signs of transglutaminase activation for the presence of IgG anti-deamidated gluten peptides or anti-TG2 antibodies is really a quite specific sign of celiac disease. And this is very different from having IgG or IgA anti-gluten antibodies. So Ben, if you want to.
Maybe just to clarify your clarification, how about an isolated IgG tissue transglutaminase? Because clinically, this is often a dead end. These patients don't have celiac disease, no matter how carefully we look for it. Isolated IgG TTG with a normal total IgA and negative TTG IgA. I really do think sometimes a false positive is just that. What do you think?
That's when you do anti-endomysium antibodies, right?
It'll be negative. I mean, these are patients.
But I think that's where it becomes interesting. And I think we have to start looking at this question a little bit differently, because having anti-transglutaminase antibodies, because there are no T cells against transglutaminase, means there has to be a hapten carrier, means there has to be T cell help. So these are very, very specific circumstances. And so it could be, as I said initially, that under viral infection, you may maybe develop that, but those antibodies will not have the same specificity than the antibodies in celiac disease that cannot be against the catalytic domain. And it could very well be that anti-endomysium has a shared epitope with those anti-TG2 antibodies. So I think what you are talking about, Ben, is so rare, is so extremely rare, Because give me the frequency of TTG, IgG, IgA anti-TTG antibodies and no celiac disease.
Oh, no, I didn't mean, maybe I misspoke. IgG anti-TTG.
Okay. Then
That's what I'm referring to.
Okay.
IgG TTG, because that is not rare. People get them checked on panels, and they have normal total IgA, and they have this isolated TTG IgG. And as far as we can tell, it's a diagnostic dead end. We don't find anything abnormal in the intestine. It's thought to just be something that we wish weren't ordered in the first place. IgG TTG.
I would agree that it's in the pediatric world as well. And then, it's not, someone may not even really be asking to order, but you order a panel, and that TTG IgG is part of the panel, and everything else is normal. Obviously, if the person is symptomatic, you end up doing an endoscopy, but I don't think there's been ever a case that has TTG IgG that's abnormal, IgA level normal, and all the other celiac antibodies being normal as celiac.
But Benno, how would you I'd be interested in what you think is actually happening under the hood pathophysiologically. They don't have TTG IgA, it's negative. They have normal total IgA. What accounts for that humoral reaction, B cell reaction of generation of TTG IgG antibodies?
I'm sure that later on Ludwig will comment on that. But again, for the physicians who listen to us and the patients, right? Usually what you do, because I think it's very important that people don't think that we are getting confused. Usually you do IgA, anti-transglutaminase antibodies, and for deamidated gluten peptides, you can do IgG. So IgG anti-deamidated gluten peptide is a valid test, and IgA anti-transglutaminase antibodies. I just want to clarify that, because I don't want people to think that their physician didn't prescribe the right tests or whatever it was. So I think the difference between IgG and IgA is actually the place where the activation of the immune cells happen, because IgA is a mark of indicating that it happened in the gut. So if those IgG anti-transglutaminase antibodies exist and there's no IgA, this means that the activation has happened outside of the gut. And so this may be completely different mechanism, because IgA is really the hallmark of activation within the intestinal mucosa. So, what that means and where that is could be interesting to look at.
There's one really important question here that I think we should just quickly address. Can you speak to alterations in biopsy approach for people with gastric bypass surgery? Ben, Maureen, what do you think about this? And Bana, do you think the gluten hits that jejunum immediately now, and then you're going to have bad jejunal inflammation just like you would in the duodenum? Anyone?
I think we're muted because we don't really know the answer, frankly. I think there's not a lot of data. I think that taking plenty of specimens from whichever part of the small bowel you can get to, the gluten gets to, is a reasonable approach.
Yeah.
What we do know is that the immune cells that are gluten specific will go through the gut. You will not just see them in one place. So very likely you would see symptoms in the jejunum. But, again, one would have to do the studies to really, assess that.
So I know there's lots of questions. There's more. I know, Maureen, there was a question for you for non-celiac gluten sensitivity. Can you just answer that in 1 second? And then we'll hand it back to Rachel. And we will come back to that question of TTG IgG for Ludwig later on. I'm sure he's listening and getting ready with that answer. But 1 second on that non-celiac gluten sensitive question.
Yeah, I just wrote a quick answer. So it said, can we, I said that non-celiac gluten sensitivity can be transient, especially in children. We don't have a lot of data about this in children, but that's the reason. And they have a long, long life ahead of them in many social situations where gluten is important. And so we do think it can be transient. So trying gluten either accidentally or purposefully and seeing if symptoms are still there is very important.
I just want to thank each one of you, Dr. Semrad, Dr. Lebwal, and Dr. Leonard, This has been exciting, interesting, and thought-provoking, and we'll continue on this discussion. But I think we can clearly say that the waters are muddy. We have a lot of symptomatology that we don't understand, but we do feel that there is some safety and some need to do gluten challenges for clinical scenarios, and we'll hear more later on. But definitely there is a need, and we're all doing it in practice. We just want to clarify, how do we do it? How much do we give? And what testing do we do? And thank you so much for clarifying that, all three of you. So appreciate that. Rachel, back to you.
Thank you all very much. We are going to take about a 10-minute break, and I just want to direct everyone back to the virtual conference URL. And within the schedule of the day, there is join session 2. You can go ahead and do that. So if people would like to take a few minutes, go grab a cup of coffee. I want to thank our speakers and also our moderators, Bana and Ritu. Thank you, Dr. Verma and Dr. Jeffrey. I apologize for the informality, but this has been awesome. And as you can tell, we are going to have a really exciting second session. I love how a lot of our questions and discussion actually are lending itself into the research side of things. So stay tuned, and we will see everyone in about 10 minutes. We will begin our second session. Thank you so much.